I do want to thank you for the opportunity to present on the impact of bariatric surgery on cardiovascular risk factors. And I want to start by introducing you to a patient of mine. This is Jack. He is in his early 60s. He is on 220 units of insulin per day with a BMI of 44, and he weighs at 322 pounds. In addition to the insulin, he's also on 2 oral diabetic medications. He also struggles with hypertension, sleep apnea, high cholesterol, COPD, and has cardiac stents placed in the past. His cardiologist has given him about 3 to 5 years to live. Whenever he would go to Walmart, his family would actually have to track down one of those little motorized buggies so that he could get around Walmart. He spends his days in his lazy boy. He just doesn't feel like doing anything else other than sitting in that and watching TV. But the final straw for him was when he was too weak to carry his 3-year-old granddaughter in from the car when she fell asleep in the backseat of his car. And this was just too much for this proud former military man. Jack is like so many of our patients. Years of poorly controlled diabetes, hypertension, high cholesterol, and morbid obesity have caused severe weakening and damage to his heart. His quality of life is virtually nil, and he's probably cut 10 to 15 years off of his life. Now, fortunately for him, bariatric surgery can offer him what he is looking for: better health, better quality of life, and even longer life. Today, Jack can even choose between procedures to have. So let me briefly introduce to you these 3 procedures. I know that you're very familiar with them. This is the sleeve gastrectomy. Currently, it is the most common procedure performed in the United States. In my own practice, this is about 70% of what I do. Basically, we turn a sac-like organ into a banana-shaped organ by taking out about 80% of the stomach. This results in a restricted procedure. Removing of the fundus of the stomach also results in a hormonal procedure because it decreases the amount of circulating ghrelin in the blood serum. There are no foreign bodies. The results are outstanding. The nice thing about this procedure is that it's a nice middle ground between the bypass and the band. It's a little safer than the bypass, although the bypass is safe, and its results are markedly better than the band. So it's a nice combination of safety and results. This is the Roux-en-Y gastric bypass. This is the procedure that everything else is compared to, and it's considered the gold standard. It's been around for decades and has the best results. Basically, you create a pouch of stomach, then you reroute the intestine to bring it back up to the pouch. This results in a restrictive procedure and also a malabsorptive procedure. If a patient is choosing between the sleeve or the bypass, oftentimes it's a personal choice. Would they rather have the slightly better results of the bypass or the slightly better safety margin of the sleeve? This is the adjustable gastric band. This used to be a very popular procedure. Now I take out more than I put in. It's a good procedure, but not a great procedure. It restricts food intake, but little else. The results are better than diet, exercise, and behavior modification, but they are clearly inferior to either the sleeve or the bypass as far as results. So those are the 3 major procedures that are performed today. About 95% of bariatric surgery is usually one of these 3 procedures here. And if there is a consistency between the 3 of them, though, it's that, particularly with the sleeve and the bypass, they have dramatic effects on cardiovascular risk factors. Of course, there are many cardiovascular risk factors. Some of them can be modified and some cannot. There are 4 modifiable risk factors that I'll be referring to throughout the remainder of my time: obesity, hypertension, hyperlipidemia, and diabetes. All of these increase the patient's risk of cardiovascular disease, and while all can be treated or controlled with medications, some better than others, bariatric surgery can improve all of these and also make it easier for you to control them, and sometimes they can even be pushed back into permanent remission, and some people would argue that that constitutes a cure, but the word cure is often debatable in medicine. So let's look at 2 articles that document the impact that bariatric surgery has on those 4 risk factors. This is probably one of the more definitive articles as it comes to and relates to bariatric surgery and its impact on cardiovascular disease. This manuscript appeared in Heart in 2012. To my knowledge, this is the largest systematic review that looks specifically at bariatric surgery and its impact on cardiovascular risk factors. The authors searched the 3 major databases from January of 1950 through June of 2012. They found 73 studies that evaluated CV risk factors. These studies included 19,543 patients. And after looking at nearly 20,000 patients in 73 studies, 44% of the patients were found to have hypertension, 24% had diabetes, and 43% had hyperlipidemia. Of those patients, the mean age was 41.7, 76% were female, which is a pretty typical number, and the BMI was 47. All 20,000 patients had some kind of bariatric procedure. The most common procedure were the malabsorptive procedures, the gastric bypass being the most common of them, with 57%. The next most common procedure was the band at 27%. Then there were other procedures, including the sleeve and the vertical banded gastroplasty, and other lesser well-known procedures. After their procedures, the mean length of follow-up was almost 5 years, with a very wide range from 3 months all the way to nearly 15 years. The average excess weight loss was 54.2%, with the range being from 16% all the way to a difficult-to-believe 87% excess weight loss. And while it's not specifically stated in the article, I think that the 16% excess weight loss is probably due to the fact that they included people in there who had a follow-up as little as 3 months. And if they would have excluded some of those patients, then likely this result would have even been better. But nonetheless, 54% excess weight loss is very good. The results as it relates to other risk factors was pretty impressive. Hypertension resolved or improved 62% of the time. Diabetes resolved or improved 73% of the time. Hyperlipidemia resolved or improved 65% of the time. And again, some of these patients had as little as a 3-month follow-up. And again, if they would have excluded those, I think these numbers would have been better, but these numbers are still very, very good. So this article directly addresses those 4 modifiable risk factors for cardiovascular disease: obesity, diabetes, hypertension, hyperlipidemia. And it shows that based on 73 studies and 20,000 patients with a near 5-year follow-up, that there's a 54% excess weight loss, a 73% resolution or improvement in diabetes, a 62% resolution or improvement in hypertension, and a 65% resolution or improvement in hyperlipidemia. Now these numbers, these cardiovascular risk factors are not outliers. I chose this large and recent systematic review to give a baseline. I could have chosen any number of randomized controlled trials or retrospective studies to look at. The numbers may differ a little bit, but the theme just kind of stays the same. And just to illustrate, I'm going to pull up one more article for you. This one is a great meta-analysis that came out of JAMA in 2004. It's one that everybody quotes from because it's just a really good study. The authors compiled 136 studies from 1990 all the way through 2003. It looked at 22,000 patients, and they looked at weight loss, diabetes, hypertension, and hyperlipidemia. So this is another great study for our purposes. The mean age of these patients was 38.9. Females predominated the study at 72.6, and the mean BMI was 46.8. The most common procedure was the gastric bypass with 32%, followed by the band with 18%. The remaining 50% were a host of various procedures that are rarely performed today, like the biliopancreatic diversion, or procedures that are never done today, like the vertical banded gastroplasty. But in 2004, there was no available data on sleeves, and so they weren't included in this particular study. So taking all the patients and all the procedures, the excess weight loss was extremely good at 61%. Diabetes resolution or improvement was 86%, which is outstanding. Resolution or improvement of hyperlipidemia was 70%. A resolution or improvement of hypertension at 78.5%. Now again, this includes all patients and all procedures, even those procedures that we don't do today. And one of the things, though, that comes up in the literature often, and it's a common theme throughout, is that the procedure of choice does make a difference. So this is the global data on all the procedures. I'm just going to tease out the bypass numbers and the band numbers just to give you an example of this. I think this will be informative for you. This is the data on just the bypass and the band, and what you'll immediately notice is that the numbers for the bypass are markedly better than that for the band. Excess weight loss for the bypass is greater than 60%, but for the band, it's less than 50%. The diabetes numbers for the bypass are fantastic at 93.2% resolved or improved, while the band is 80.8%. But that doesn't even tell the whole story. The numbers in parentheses is the percentage of patients in whom the diabetes resolved completely. So in 83.7% of the patients who had a gastric bypass, their diabetes resolved completely. And while the number for the band is just 47.9%. And that is a huge difference, and it's part of the reason why bands are rarely being performed today. The results just aren't as good as sleeves or bypasses. And I'll just let you read those other numbers there. But no matter how the data is looked at, or no matter how the data is examined, bariatric surgery has a dramatic impact on cardiovascular risk factors, but the procedure does make a difference in those results. And just as kind of an aside here, the sleeve, the data would suggest, is in between that of the bypass and the band, with the results being much closer to the bypass. So I put these two studies side by side. The top numbers were the first systematic review. The second numbers were the meta-analysis that we just looked at. Both studies included 20,000 patients. Both studies looked at 4 modifiable risk factors for cardiovascular disease. And both studies noted the dramatic impact that bariatric surgery has on risk factors, also noting that the procedure makes a difference in the outcomes. And if you'll indulge me for just a second, I want to take the remaining minutes here and show you how bariatric surgery is really kind of changing the landscape for one of those diseases in particular, and that's diabetes. So impactful is bariatric surgery on diabetes that in 2015, when the Cleveland Clinic named the top 10 medical innovations of the past decade, number 3 on that list was bariatric surgery for the control of diabetes. Bariatric surgery really turns on its head the treatment of diabetes. And to date, there have been 15 to 20 randomized controlled trials that clearly demonstrate the superiority of bariatric surgery over intensive medical therapy for the diabetic. And so overwhelming was this evidence that a joint statement was released by 5 international diabetes organizations detailing their recommendations for bariatric surgery for type 2 diabetes. And this statement was just released in June of this year in Diabetes Care. And you'll notice that the title of this article refers to metabolic surgery, and that's the direction that my specialty is taking. It's not just the weight loss effects, it's also the metabolic effects. And many of these metabolic effects, including the effects on diabetes, are independent of the weight loss that they experience after their procedure. So as I mentioned, there were 5 international diabetes societies that put together and ratified this consensus statement. Among them were the American Diabetes Association and the International Diabetes Federation. In addition, there are almost 50 international medical and surgical societies also endorsing this consensus statement, including the American Association of Endocrinologists, the American College of Surgeons, the Obesity Society, and the Endocrine Society, just to name a few of the more recognizable ones. The need for this new consensus statement was based on several lines of reasoning. However, there were a couple of things that jumped out to me in particular. The first is that in spite of the evidence, there's no current treatment algorithm for diabetes that includes surgery as part of the treatment plan. And secondly, the treatment plan should be independent of BMI because the resolution of diabetes is largely independent of the weight loss. And this is their treatment algorithm. I hope you can read that in the back there. But note how the treatment algorithm that they're proposing is starting with diabetes and not with obesity. Now, this is a significant change. A diabetic with a BMI of greater than 40 in this algorithm would be expedited automatically for surgery. A person with a BMI of 35 to 40 and poor glycemic control also gets surgery recommended, while it should even be considered if their BMI is 35 to 40 and they have reasonable glycemic control. If the BMI is between 30 and 35, poor glycemic control also results in consideration being given for surgery. And notice how the algorithm changes how we look at things. In the past, and historically, what we would look at is we would start with the obesity, and then one of the beneficial side effects for the surgery for obesity is that they would have resolution of their diabetes. Well, now what we're doing is we're doing surgery for diabetes, and one of the beneficial side effects for their procedure for diabetes is the weight loss. This is a very different thought process, but it is supported by solid data. It is recommended by multiple specialty societies. And this new thinking will not only have a dramatic impact on diabetics, but also on the end organ damage that is brought on by decades of hyperglycemia, the heart being just one of those organs. So to summarize, bariatric surgery has a dramatic impact on cardiovascular risk factors. Excess weight loss between 54 and 61%, diabetes resolved or improved 73 to 86% of the time, hyperlipidemia resolved or improved 65 to 70% of the time, hypertension resolved or improved 62 to 78% of the time. And we also saw that through the literature, there's this thread that the procedure does make a difference. Bypasses are better than bands, and sleeves are also better than bands. And lastly, we saw that bariatric surgery is changing the treatment algorithm for diabetics. Excuse me. So remember Jack, because of his morbid obesity and relatively uncontrolled diabetes, high cholesterol, and hypertension, a gastric bypass was performed on him, and his results were outstanding. The day of surgery, I took Jack off all of his diabetic medications and his routine insulin, and I put him on a sliding scale. He came in the hospital on 220 units of insulin per day. He went home on a sliding scale of 4 units, and 2 weeks later, he was off all of his insulin. He was off all of his oral medications, and he has been off of them for 5 years now. He is off of his CPAP. His cholesterol profile has normalized. He is off all of his medications for his hyperlipidemia. He does still take one medicine for his hypertension, but even now his hypertension is much better controlled and is easier for the doctors to control. His pant size dropped from a 50 to a 34. He is lost about 110 pounds overall. He can now walk for 4 miles uninterrupted, and he has more energy, he says, than when he was in the military. And he can carry his granddaughter now wherever he wants to. And so his quality of life is immeasurably improved. That's all that I have, but I'll be wandering around here, so if anybody has any questions, feel free to grab me afterwards.